All right, as I said, I'm Amy Dahlman, and I'm with Dancing Sky Area Agency on Aging. And we cover 21 counties in Northwest and West Central Minnesota. And we do all kinds of different services and supports, and all of it's really geared towards keeping older adults healthy, active, independent in their communities. And we like to do outreach and education on a variety of topics. And we also provide services through the Senior Linkage Line, which is a toll-free statewide number in Minnesota that people can call and get information and resources and connection to services. But I could talk about that all day. So instead, I'm going to turn it over to Molly. So welcome, Molly. We're really excited to hear about this. I've actually heard from a variety of sources that this is a great presentation. And so I'm really looking forward to this. So thank you for doing this.
Yes, thank you, Amy. And yes, thank you for reaching out and getting this set up. So I am a strong believer that rural community education is the key to keeping people healthy, because the more you know, the more you know. Thank you again for inviting me to come here. So hello, everyone out there in virtual land. I'm going to share my screen here. All right, can everyone see my screen?
We can.
Excellent. So today's presentation is a very important topic on stroke recognition and prevention. Again, I grew up in a small rural community here in North Dakota. And so I know how important it is for health educators to get out into our rural communities and provide education. And as the stroke program educator at Essentia Health in Fargo, one of the topics I really love to go out and talk to people about is how do we recognize the signs and symptoms of a stroke? And then after recognizing the signs and symptoms of a stroke, what can we do? What can you do as patients, as individuals, to prevent a stroke? So it's kind of going to be hard doing this virtually, but I'm thinking maybe at the end, if you guys have questions, I welcome questions. Normally when I come out to our rural communities, it's a very interactive presentation. So if there are questions throughout, go ahead and throw them in the chat box, and I'm sure Amy will let me know what they are. But again, if you think of something or you want to ask something, please feel free. There'll be time at the end to do that. So again, I said my name is Molly Murch, and I'm the stroke program educator here at Essentia. I've been a nurse for 13 years and got my master's in nurse education from UND in 2020. I've done some teaching at the local colleges, including NDSDS and Rasmussen. And then this position opened up about a little over a year ago. And my passion has always been nursing and education, and now I get to do a combination of the two. So I'm excited to be here. So just some disclosures. I'm here to talk to you guys about stroke recognition and prevention. I have no conflicts of interest. There's no commercial support. I've agreed to disclose to participants prior to presentation if there's any off-label uses, which I have none. So normally during this part of the presentation in the rural community, I always ask people to show of hands of how many people know someone who's had a stroke personally and is known somebody who's had a stroke. So one thing I'm going to share with you here, so I'm going to stop sharing this screen. So one of the things is, how would you know if one of your loved ones, a family member, a friend, whoever it may be, how would you know that they're having a stroke? So these little video series I have is called Stroke Through Their Eyes. And the first video is on witnessing somebody having a stroke. So it's just a quick little 2-minute video. And I'm going to share that with you. So let me make sure I do share my sound. And then I gotta stop that again. Technology is always fun. So share my screen again, and I go here. There we go. And then, oh, my toolbar is in the way. Go away. There we go. All right, so again, this first video is recognizing signs and symptoms of a stroke. Again, you are the witness. You are the witness to somebody having a stroke. So I will hit play, and then Amy, if you want to let me know if you guys can see and hear this.
Now he's been wanting to put garlic.
Could you hear that, Amy?
Yes, we can hear and see it.
Wonderful. All right, here we go.
Now he's been wanting to put garlic chives in everything.
Well, not everything.
Dad, the side of your face is drooping. Mom?
It's probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Gracie, call 911.
I just
Honey?
Dad!
Tim!
I need an ambulance to 7th floor
Tim!
Avenue.
Tim, look at
I
me,
don't know
Gracie.
what the
Tell them to hurry.
Tim,
Look at me. Look at me, Tim.
Mom, what do I tell
I don't know. I think he's having a stroke.
I think my dad is having a stroke.
Tim, what's going on, baby? My husband. He. I think he's cold. Are you cold, honey? Are you cold? Okay. Gracie. See, Gracie's gonna come, sweetheart. We're just gonna go. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Okay. Huh? I'm right here. I'm right here. Gracie, meet us there. I'm right here. I'm right here. Okay. Okay, here we go. You just stay right here. You just stay and breathe. Just breathe. Tim? Tim?
Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery.
So I don't know if anybody wants to speak up or it wants to put something in the chat box. What are your feelings after watching that video? What are some of your first impressions?
I felt the panic right with the family as it was happening.
Yes, absolutely. Scared. Yep, it is. It's a very scary thing to, they were getting ready to have dinner and all of a sudden, boom, he starts having the facial droop, slurred speech. He can hardly sit up in his chair. So it happened suddenly. So yeah, it's very scary. Yes, and good thing we called the ambulance right away, which we're going to talk about. So yes. Now I'm going to show you the same video, but it's through the eyes of the person actually having the stroke. So we watched the video of being a witness to somebody having the stroke, but now would you recognize if you yourself were having a stroke? So again, it's the same video, just through the eyes of the person having the stroke.
Wanting to put garlic chives in everything.
Well, not everything.
Dad, the side of your face is drooping. Mom?
It's probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Gracie, call 911.
I just
Dad!
Tim?
I need an ambulance to 7th floor Avenue.
Tim, look at me, Gracie.
Tell them to hurry.
Tim, look at me, Tim.
I don't know. I think he's having a stroke. Sweetheart. My husband. I think he's cold. Are you cold, honey? Are you cold? Okay. Gracie? See, Gracie's gonna come, sweetheart. We're just gonna go. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Huh? I'm right here. I'm right here. Gracie, meet us there. I'm right here. I'm right here. Okay. Okay, here we go. You just stay right here. You just stay and breathe. Just breathe. Tim? Tim?
Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, You're looking at a full recovery.
Any thoughts on that one? So again, scary. And then not only are you scared, being the person having a stroke, you can see the panic and the look in the family members' faces. So I like to share those two videos just as kind of an intro to what we're talking about today. So one more time, I'm going to share my screen, pull up my PowerPoint. So again, this would be the time, everybody can see that? Okay. So for a long time, let's see if my thing will go forward here. So for a long time, it was a myth that only the elderly can have a stroke. Only people over the age of 65 can have strokes. Well, we know that that's far from the truth. Unfortunately, we are seeing younger and younger people having strokes. Yes, our elderly people still do have strokes, but again, it's a myth that only the elderly can have a stroke. And so I like to put some familiar faces up, and I'm sure you guys recognize a lot of these faces. And as you can see, we have younger people, middle-aged people, and elderly people, all who have suffered strokes. I like to keep our local boy, our Minnesota boy. If you guys remember Kirby Puckett from the 90s, he was a phenomenal baseball player for the Twins. And unfortunately, at the age of 48, he suffered a hemorrhagic stroke and died. Betty White from the Golden Girls, she was 99, and at the end of last year, she did pass away. I see some people commenting on there, very good. So Betty White, they did determine 6 days prior to her death, she suffered a stroke. I'm hoping everybody knows who this gentleman is. Sometimes when I do this presentation to our younger nurses, they don't know who this gentleman is, but former President FDR. He actually was sitting for a presidential portrait when he complained of a severe headache and he slumped over in his chair, and that was it. He was 62. Actress Sharon Stone and singer/rocker Bret Michaels, both of them suffered a hemorrhagic stroke in their 40s. It won't let me do that. Anyway.
And Molly,
Yes.
Molly,
Yep.
there is one comment that somebody had a stroke at age 20.
Yep.
And then there's a question about if you can get your own help if you are alone and having a stroke.
Very good question. That's a common question I get. So strokes again can and do occur at any age. And the next this next slide, the person I was going to show you, her name is Amelia Clark here in the left lower. She was actually 28 when she suffered a stroke. So again, it could be due to a family history. It could be due to undiagnosed conditions such as a blood clotting disorder, elevated blood pressure. Yes, strokes can and do occur at any age, even as young as 20 years old. So, and then to answer the question, let's say you live alone. I live alone as well. So yeah, it's kind of scary to think about, okay, well, I have these risk factors for a stroke. What would I do if, all of a sudden I couldn't reach for the phone or I couldn't call for help? After the presentation today, what I want you guys to do is think about your personal risk factors. And if you are noticing that you have a majority of the risk factors we're going to talk about, that's probably time for you to reach out to your doctor or even to the public health office. Amy probably could even get you in touch with someone. You're probably going to need what's called a life alert. Okay. So if you live alone at home and you have if you have risk factors for a stroke and all of a sudden you have an episode, you're able to hit that life alert thing, a button on your necklace, and get somebody to your house quickly. Okay. That answer hopefully answered the question. Again, some more familiar faces. Everybody probably, or some of you probably remember Luke Perry from 90210. He continued to act into his 50s, and just a couple of years ago, at age 52, he did suffer a ischemic stroke and died from that. Another one of our Golden Girls, Blanche, she died of a stroke. Country music singer Randy Travis, his is kind of an interesting case. Unfortunately, Randy suffered from alcoholism for a long time. And due to his chronic alcoholism, he developed some congestive heart failure issues. He wound up going into the hospital due to his congestive heart failure issues, wound up throwing a clot from his heart. Clot went from his heart up to his brain, and he suffered a very debilitating stroke. He's coming along, but his stroke left him with difficulty speaking and difficulty walking. So obviously being an entertainer and a singer, very difficult for him. We already mentioned Amelia Clark. She is an actress. And again, at age 28, she suffered a stroke. Dick Clark from the New Year's Eve celebrations, he suffered a stroke and lived a few years after he suffered a stroke, but you could definitely tell he had some deficits as far as weakness on one side of the body and ability to speak. Some more familiar faces: actor Tim Curry, country music singer Loretta Lynn, Bob Barker. A lot of people don't know that, yes, he is still alive. He actually will turn 98 years old this year. Or he turned 98. I believe his birthday is in January, but about 20 years ago, he was actually just sitting poolside at a hotel in California and suffered a stroke. Two of the Three Stooges, Larry at age 72 or 77, I believe, had a stroke, and then Curly actually suffered multiple strokes throughout his young life and died at age 48. So again, you can see a number of people at any age can have a stroke. The last thing I want to mention is this gentleman right here. A lot of people don't know who this gentleman is on the left lower corner, but there's a reason why I put him on here. This gentleman's name is Michael Johnson, and back in the 90s, he was a phenomenal Olympic athlete for the US, won multiple gold medals in the Atlanta Olympics. He did personal training, he had a gym and everything like that. And at age 51, he suffered a stroke, and this stroke left him unable to walk. So again, being somebody who was a runner and is at one time the fastest man on earth to now not knowing how to walk or not being able to walk. He has slowly gotten back to his baseline, obviously won't ever be back to his Olympic days. But again, this shows that somebody, even in their prime health, an Olympic athlete, can suffer a stroke. Okay, any questions right now? Okay.
No questions?
No questions? Okay. So let's do a quick review. So what is a stroke? Okay. So right now, all of you out there, and myself and Amy and everybody else who's on this presentation, we are doing just fine. We are getting oxygen and blood flow to our brain, so we're not having any neurological deficits. Our heart and our brains are very well connected. So how do we get oxygen and blood flow from our heart to our brain? Through our arteries. So our blood and oxygen comes from our heart, goes up through the arteries in our neck and into the vascular supply in our brain. Okay. However, when somebody has a blockage in one of those arteries in their brain, oxygen and blood flow cannot get to that area of the brain. When an area of the brain lacks oxygen and blood flow, that area of the brain starts to die. That patient is having a stroke. Okay. Stroke is a brain attack and is a medical emergency. We a lot of times use the phrase time is brain, and it is very true. We need to get these patients into the hospital quickly and get them treatments. So let's look at some statistics of stroke. Someone in the US has a stroke every 40 seconds. As an educator and nurse, I was kind of surprised by the second bullet that every 4 minutes someone dies of a stroke in the US. That seems like quite a few people. As a nurse and as an educator, I'm not a big fan of this third bullet point. Every year, more than 795,000 people in the US have a stroke. And of those people, over 600,000 of them are newer first-time strokes. So what that tells me as a nurse and a nurse educator, I need to continue to get out to our rural communities and educate patients on stroke, risk factors, and how they can monitor for signs and symptoms of a stroke and what they can do to prevent a stroke. Unfortunately, I have a feeling that this number is going to be up. As you all know, we are coming off of 2 years or 2.5 years of COVID. There is definitely a link. There is lots of research being done out there regarding the link between COVID and stroke. So unfortunately, I think we're going to see this number go up in the next few years. Hopefully it will peak and then go down again. More to come on that. Stroke is the number 5 cause of death in the United States and is one of the leading causes of long-term disability. However, we have been making progress on long-term disability because we're able to get these patients to the hospital more quickly, get them treatment, and then a lot of times these patients will see therapy. So physical therapy, occupational therapy, speech therapy. By all combination of all these things results in decreased long-term disability. So we're making some strides. We will continue to do that as well. So stroke risk, we already talked about it. Stroke risk increases with age, but strokes can and do occur at any age. Unfortunately, we are seeing younger patients due to COVID, drug use, and dissection. And what I mean by dissection is people who maybe have chiropractic manipulation, or maybe you're in a motor vehicle accident. So in the back of our neck, we have 2 arteries, very important arteries called our vertebral arteries. These arteries supply a lot of blood flow to the back of our brain. But sometimes when somebody's in a motor vehicle accident or has chiropractic adjustment, that sudden manipulation to the neck can put pressure on those arteries, causing them to rupture. It's very, very rare that it happens. I believe it's like 1 in a million, but unfortunately we have seen some patients who have had that. So some statistics and now some facts. So probably most of you out there, including myself, 50% of the US population has hypertension. At age 50, the total life expectancy is 5 years shorter than someone without hypertension. During the presentation today, you will see that hypertension is the cause of every single type of stroke we see. Uncontrolled hypertension is a very common cause of stroke. So this is another part in the presentation where I normally ask people if they know what atrial fib is. So AFib or atrial fibrillation, okay? What atrial fibrillation is so normally if our hearts are good and healthy, our hearts should go lub-dub, 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 okay? Nice rhythm. When someone has atrial fib, their heart rhythm is almost like a butterfly's wings. It's very abnormal. It can be really fast and then it can slow down. It can be really fast and then it slow down, okay? When someone has atrial fib, they need to be on medication. We cannot have the heart rhythm being abnormal because people are at risk for throwing little clots from their heart, okay? AFib is a big risk factor for somebody in having a stroke. As you can see, atrial fibrillation raises a person's chance for having a stroke up to 5 times. Another big contributing factor to having a stroke is smoking. Okay, smoking raises a person's risk 2 to 4 times higher than non-smokers. This includes someone who's chronically exposed to secondhand smoke. Okay, and then another big one I want to mention to all of you out there, it's very important that you know your family history. So when you go into your doctor once a year or every 6 months, a lot of times, if you're a new patient to them, they're going to want to know, what is your family history? What conditions did your mom have? What conditions did your dad have? Is there any family history of stroke or heart disease? Okay, because when somebody has a first generation or first degree relative, this increases that patient's odds of having a stroke by 12%. And what do I mean by first degree relative? Mom, dad, grandma, grandpa, brother, sister. So if there's any first degree relative that you know of that's had a stroke, you need to let your doctor know, because that is going to eventually put you at an increased risk for having a stroke as well. Okay. Any questions so far? Okay.
I don't see any questions.
Perfect. I hope I'm going at an okay pace, and again, just stop me if there's any questions. So let's take a quick look at the different types of strokes we see. There's 3 types: ischemic, hemorrhagic, and TIAs. But first of all, I want to do just a little anatomy review with all of you. So our brain is very interesting in the fact that when someone is having a stroke on the left side of their head, so the stroke is occurring in their left brain, there's an axonal pathway that crosses over. So when somebody's having a stroke on the left side of their brain, the pathway is going to cross over and our right side is going to be affected. So even though I'm having a stroke on the left side, my right side is going to become weak. I may notice some facial droop on my right side. Okay. Opposite of that is when I'm having a stroke on my right side, my left side is affected. Okay. It's just an interesting thing that our brain, the pathways of our brain do. So ischemic stroke. This is the most common type of stroke that we see. As you can see, 87% of all strokes are ischemic strokes. And what do I mean by ischemic strokes? There's two types of them, thrombotic and embolic. With these kind of strokes, a clot forms somewhere in the body. When a clot forms in the actual artery in your brain, like it's showing in this picture, so again, here's my arteries, here is some plaque or atherosclerosis that's built up over time. And what happens is little particles of blood eventually gather and form a clot. So now here's my oxygen-rich blood flow right here, and it cannot get up into my brain where it needs to go because I have a clot blocking it. Okay, that is a thrombotic type of ischemic stroke, again, where the clot happens in the arteries in the brain itself. Okay, we see these types of strokes with our elderly population, those with high cholesterol, those who are smokers, uncontrolled diabetes, those kind of things. Different than that is what we call an embolic stroke. So an embolic stroke is still an ischemic type of stroke, but an embolic stroke happens when a clot forms elsewhere in the body. So maybe somebody's recently had hip replacement surgery or knee replacement surgery, or maybe they have atrial fib, where again, their heart has an irregular rhythm. They're at risk for throwing tiny little clots from their heart. Okay, what happens is these clots break loose, travel up the bloodstream, and go to our brain. So this is an embolic type of stroke. These ones are often a result of AFib, heart disease, oral contraceptives, and surgery. So that's why if any of you have ever had surgery or maybe know someone who's had surgery, such as knee replacement, hip replacement, and sometimes like the big hernia operations, you're started on Lovenox or heparin, that shot in your stomach. Why? Because we need to make sure we're keeping that blood thin. Okay, so what's important for you guys to know? So if somebody you know starts having signs and symptoms of an ischemic stroke, we have treatment for these patients, okay? And there's lots of facilities in Minnesota, northwestern Minnesota, and here in North Dakota that can treat patients who are having an ischemic stroke. The key is, though, we need to get you to the hospital quickly. Once you start having signs and symptoms of a stroke, you have 4.5 hours to get into the hospital to get treatment. Treatment of this is called Alteplase. What is Alteplase? It's a clot busting medication. So again, here's my big old clot. We're going to give somebody a medication, and what the medication is going to do is going to break up this clot, hopefully to dissolve it, okay? Because again, a clot is causing decreased oxygen and blood flow to the rest of my brain. So I need to get this clot broken up, okay? So again, we need to get you to the hospital quickly within 4.5 hours of your last known well. We need to get you here and get you that clot busting medication. Of course, you have to meet the criteria of that. A lot of the hospitals in northwestern Minnesota and the hospitals here in North Dakota have the capability to get you this IV Alteplase. But let's say you are having what's called a large vessel occlusion stroke. What I mean by that is in our brain, we have lots of arteries and vessels. When one of those large arteries in our brain becomes blocked by a clot, we have significant decreased blood flow and oxygen going to our brain. So these are the patients with a large vessel occlusion stroke. They come in and they are in bad shape, okay? We can do a procedure here at Essentia in Fargo where they can go up into the patient's brain and take out the clot. So I want to show you an example of that. So this is actually a case that we had here at Essentia. And if you look at this picture on the left side, there's nothing going on. There's no blood flow to this area of the patient's brain. This patient is actively having a stroke. So what our doctors will do, obviously, we rush this patient to the hospital, do some imaging, do some lab work, and we find that this patient has a large clot blocking oxygen and blood flow to a huge portion of their brain. So what our doctors will do is they take a catheter device like this. It's called a thrombectomy catheter device. And what they do is they make a small incision in the patient's groin. They feed that catheter all the way up into the patient's brain. Once they're in the patient's brain, they're able to identify the clot. They take this catheter device and go through the clot. Once they're through the clot, they open up this device, as you can see, and this device is made of fibers that attract that clot, tells it to come here, okay? Once that they are able to capture that clot, they pull that clot out of the brain, back out through the body. Once that is done, this is what happens. Much better, okay? Yes, we have an area of infarction, an area of decreased oxygen and blood flow. So this area of the brain, this light gray area, is dead tissue. However, look at how much tissue we were able to reperfuse. Okay, we went from treating a patient who was having a very significant stroke, probably a life-changing stroke, to a smaller size stroke. Okay, again, we need to get these patients into the hospital quickly and get them this treatment. I will tell you that if a patient is having a large vessel occlusion stroke, they need to get to Fargo. Fargo is the only comprehensive stroke center in our area. We have 2 comprehensive stroke centers in North Dakota and in this area of North Dakota and Minnesota. Unfortunately, they're both right here in Fargo. So again, if you are starting to have signs and symptoms of a stroke, you're probably going to go to your local hospital, like in northwestern Minnesota. They're going to evaluate you, initially get that alteplase, and they're going to be shipping you here to Fargo. Okay, why? We are a comprehensive stroke center, so we can take care of patients with the smallest strokes and the most difficult stroke cases. Okay.
Molly, can I ask a question?
Oh, absolutely.
So you talked about those medications or those procedures need
Yep.
to be administered
Yep.
within a certain amount of time before last known well. What does
Yes.
that mean, last known well?
Excellent question. So last known well is what our treatment is dependent on. So what I mean by last known well is when is that patient at their baseline, at their normal, okay? A lot of times we'll have what are called wake up strokes. And so a patient goes to bed, let's say at 10:30 tonight, everything's good. Maybe they're getting ready to go to the cities tomorrow. Everything's good. They're not having any neurological changes. Now at 7 a.m. the next morning, the patient wakes up and they notice they feel weak on the one side. They walk into their bathroom and they look in the mirror and they notice they have a facial droop. And when they go to pick up their toothbrush, they can barely raise their arm. So they're having a sudden change in their neurological function. Their last known well, when they were last at their baseline, was last night at 10:30. Their discovery of symptoms is now that next morning. Our treatment is based on last known well. Does that make sense?
That does, thank you.
You're welcome. So that's why recognition of signs and symptoms of a stroke, which we're going to talk about in just a minute here, is so important, okay? So we talked about ischemic type of strokes. Now the next type of strokes are the hemorrhagic strokes. These are a little bit more tricky to treat. Luckily, we don't see as many hemorrhagic strokes. So hemorrhagic strokes account for 13% of all strokes. Just like there were 2 types of ischemic strokes, there's 2 types of hemorrhagic strokes, what are called intracerebral hemorrhages and subarachnoid hemorrhages. So let's take a quick look at these. I love this picture. I found this picture just a few weeks ago. It shows the beautiful vascularity of our brain. A lot of times I will have patients who say, well, I thought our brains needed blood. I thought we needed blood in our brains. Yes, we absolutely need blood in our brains, excuse me. But where does that blood need to stay? Inside of these arteries and vessels, okay? The problem happens when one of these arteries and vessels rupture and we now have blood leaking onto our brain tissue. So again, you can see all the arteries and vessels. When one of these ruptures, we now have blood leaking onto our brain tissue, and that's not good. Blood is actually toxic to our brain, okay? So let's look at the different types here. So the first type is an intracerebral hemorrhage. So with this picture, you can see there's large vessels, and then off of my large vessels in my brain, I have these tiny little vessels. I'll go back to this picture as well. As you can see, we have these larger vessels, and off of our larger vessels, we have these tiny little vessels. Okay, our arteries, and then the little things are the vessels, okay? So I like to use the analogy of when you put a new pair of, or a new set of tires on your car. Okay, you drive on those tires, you drive for years and years and years. Well, what's happening to the wall of those tires? It's getting weaker and weaker and weaker till eventually, oh, you hit a nail and boom, it pops. No different than with these tiny little arteries in our brain. These arteries are highly susceptible to elevated blood pressure. Okay. So with these, when again, years of elevated blood pressure, somebody just doesn't take medication, maybe doesn't know their blood pressure levels, these little arteries again can only take so much pressure from the elevated blood pressure till eventually they just say, I can't do it anymore, and they burst. We now have blood leaking onto our brain tissue. Okay. So intracerebral hemorrhages, I told you earlier in the presentation, hypertension. The primary cause of ICHs are hypertension. Unfortunately, we also see ICHs a lot with our younger patients due to this right here, drug use. And I'm sure there's drug use up in the areas where you guys are from. It's a, a rural issue. It's a national issue. Unfortunately, we're seeing a lot of younger people who are chronic drug users. Again, when somebody takes a drug, it causes a sudden spike in our blood pressure. So somebody who is chronically using drugs, it's going to cause these sudden spurts in our blood pressure, weakening those artery walls, putting them at risk for rupturing. With these types of strokes, we're going to see those neurodeficits like we talked about with ischemic, but with these patients, they're also going to develop severe headaches, nausea and vomiting, and their blood pressures are going to be through the roof. And that's because our body is trying to compensate for the bleeding in our brain. The next type of hemorrhagic stroke we see, it's a little bit of a scary one. They're all scary, but this is the bad one as far as getting you to the hospital and getting you treatment quickly. This type of hemorrhagic stroke is called a subarachnoid hemorrhage. So if I click back on this picture of my vascularity of my brain, as you can see, the arteries in my brain are nice and smooth, okay? However, what can happen in some patients is they can develop what's called an aneurysm. What does this look like to you guys? A balloon, okay? And that's exactly what an aneurysm is. An aneurysm is a weakened balloon area on the artery wall at risk for rupturing. So think about a balloon at a birthday party or a water balloon. You can only put so much air into that balloon, and then what happens? The walls stretch, stretch, stretch. And if you're not careful, you blow too much air into that balloon, it bursts, okay? No different than when somebody has an aneurysm on their wall, okay? Again, this wall of the aneurysm can only take so much elevated blood pressure, so much chronic drug use, so much smoking until the aneurysm walls becomes thinner and thinner, and eventually it ruptures. Why this type of stroke is so bad is we now have blood pouring onto our brain tissue, causing a stroke. But what else? The other reason why these are so bad is we have significant swelling that happens with this type of stroke. And because our subarachnoid space is in our brain, between our brain tissue and our skull, that's why these are so fatal. We have to get these patients to the hospital pretty much within minutes. Otherwise, it's not going to end up well. But what is important for you guys to know with this? Symptoms. So again, risk factors, I mentioned it already with our other types. Hypertension, uncontrolled hypertension, again, weakens those artery walls, putting them at risk for rupturing. Smoking, cocaine abuse, alcohol abuse, race, and family history. But what's important for you guys to know, thunderclap headaches or worst headache of my life. So people who have survived subarachnoid hemorrhages or aneurysm ruptures describe just that. They say, oh my gosh, I feel like I'm having the worst headache in my life, or I feel like something just blew up or went off in my head. That is that aneurysm rupturing. So if you are ever with anyone, family members, a friend, maybe somebody in the community, and all of a sudden they're complaining of a horrible headache, the worst headache of their life, or they say, oh, I just feel like something blew up in my head and I'm nauseated and my vision isn't very good, you call them an ambulance and get them in right away. Most likely they have had an aneurysm that's ruptured, and we have just minutes to get them in and get them treatment. Okay. However, does that mean that when somebody presents to the hospital with an hemorrhagic stroke, there's not much we can do for them? No. Probably about 50 years ago, there wasn't much we could do, but we now have a team of providers at Essentia that can provide care to these types of patients. So there is definitely hope out there that even if you present with a hemorrhagic stroke, we can help you. We can help to treat this problem. Okay, any questions on hemorrhagic strokes? Excellent. The last one, and probably the most important one, especially for our rural communities, is what we call a TIA. Maybe some of you know somebody who's had a TIA, or maybe you yourself has had a TIA. What does a TIA mean? We call those warning strokes. They used to be called mini strokes, but we now call them warning strokes, and we'll talk about why. So what a TIA is a temporary period where you have lack of oxygen and blood flow to an area of your brain, causing you to have symptoms similar to that of a stroke. So I like to tell the story. We had a patient who came in, her and her husband were at Menards in Moorhead, Minnesota here, and they were shopping for faucets. The husband goes around one way, the wife goes around the other way, and she picks up a faucet box, okay? She picks up a box to hold on and look at it, okay? Her husband, a couple minutes later, comes around the aisle and says, oh, did you find something? And she looks up at him. She's got her facial droop. She's mumbling, so okay, mumbled, slurred speech, and the box she's holding, she drops it. Suddenly, her arm goes limp. Okay, sudden neurological changes, weakness in her one extremity, slurred speech, facial droop. It looks like she's having a stroke. So the ambulance or the people at Menards call in and say, oh my gosh, something's wrong with this lady. The ambulance comes and picks her up, brings her here to Essentia. We do the scan, we do lab work, we run her through everything. Okay. Unfortunately, even though this patient's last known well was in 4.5 hours, she was on Coumadin and couldn't receive the alteplase. Okay, that was one of the indications where she couldn't receive alteplase. We still admitted her to the hospital and kept her under close observation. Throughout the day and into the evening and to the night, she was able to start moving that arm. She could talk a little bit. Her speech was still a little slurred, and she still had a little bit of facial droop. The next morning, we brought her down and did what's called an MRI. An MRI is a very specific test where we look at blood flow in the brain. That helps us to diagnose a stroke. That next morning, she went and had an MRI. No evidence of a stroke. Nothing picked up on MRI. By that next afternoon, within 24 hours of her admission, she was back to her baseline. Her weakness was gone, her facial droop was gone, and she was able to talk. So what in the heck happened with this lady? She had what's called a TIA. As you can see in this picture, there's a little blood clot that was blocking oxygen and blood flow to that area of the brain. So she started having signs and symptoms of a stroke. However, her body recognized, uh-oh, something's not right here, and was able to take care of that blood clot on its own. So even though her imaging and everything was negative for a stroke, she was the perfect patient to get into the hospital and run her through all the testing. Why? Because it's not normal for anyone to ever throw clots. You should never be throwing clots in your body. Something is causing you to have these clots, whether you have undiagnosed AFib, whether you have uncontrolled high blood pressure, maybe you have a family history, maybe you have a blood clotting disorder such as factor V. There is some reason why your body is throwing clots, and we need to figure it out. The reason why we need to figure it out is people who have a TIA, 1 in 3 of those people will go on to have a full stroke within a year. However, we live in a very rural area and a farming area, and I will say this because my dad was a farmer and my 2 brothers are farmers. Very stubborn, very, very stubborn people, okay? You can't pull them out of the field no matter what during harvest, okay? So these are the people who are like, oh, I just slept wrong, or I'm just tired, that's why my vision is changing, or I don't know what's going on. I'll go to the doctor in a couple days after I'm done, with the wheat harvest. Okay. No, these are the people we need to get into the hospital quickly and get them treatments. Okay.
Molly, we have a couple things in the chat.
Yes.
The first one is a comment about they appreciate how you explain our complex, amazing bodies.
Thank you.
And then the second one is a question. Can there be a very small, slow leak rather than a large burst?
Yes, great question. Yep. So a lot of times, and with our hemorrhagic strokes, so let me just stand back up here. So with our hemorrhagic strokes, both with our intercerebral hemorrhages and our more so the intercerebral hemorrhages can be a small leak. So like we talked about, looking at this picture of the brain, when one of these tiny little arteries here bursts, we can have little drops of blood or little small amounts of bleeding onto our brain. Sometimes these can go undiagnosed for a long time until somebody has a problem. However, so that's with our ICHs, our intercerebral hemorrhages. They can cause a slow leak. However, with the subarachnoid hemorrhages, those happen fast and they happen suddenly, where that blood is pouring onto our brain tissue. Because you think about this large artery we have here, it's now ruptured. This large artery was carrying lots of blood. Once that artery ruptures, all of that blood that's housed or travels in that artery comes out. So yes, you can have a condition where you have a very slow brain bleed, like an ICH, but eventually that blood is going to become toxic to our brains and you're going to have signs and symptoms of a stroke. Did that help? Any other questions right now?
I don't see any other questions.
Wonderful. So the next 2 things are kind of what I like to call the meat and potatoes of my presentation. So we talked about some of the statistics of stroke. We talked about the different types of stroke and the treatments we have for these strokes. But how do we know when someone is having a stroke? This is one of the big things I want you to take home today, is how do you recognize the signs and symptoms of a stroke? Some of you may have heard of this, but me as a nurse, you as patients, we all need to be fast. B-E-F-A-S-T, be fast. Not just be fast in the actual sense of like quick, 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 but be fast as you can see: balance, eyes, facial droop, arm weakness, speech difficulty, time to call 911. So there's kind of 2 different reasons why we want to be fast. So let's take a look at these. So the first one is balance. Sudden change in that patient's balance or coordination. So let's say somebody's walking along and all of a sudden they start leaning one way, okay? Or let's say somebody's sitting in a chair, you go in to do something, and the next thing you come in and that person is like this in the chair, leaning over to one side, okay? They have total loss of balance to the one side. Coordination. So let's say you are drinking a cup of coffee or taking a drink of your pop, and all of a sudden I can't coordinate my arm to bring the pop up to my mouth. My coordination is suddenly gone. Okay, so B stands for balance. Sudden loss of balance and sudden loss of coordination. Next one is E. E stands for eyes. This is a big one we see with our patients. So sudden visual loss or visual changes. So all of a sudden your eyes become super blurry, almost like you have a veil over your eyes. And what do we tend to do when our eyes are kind of dry and blurry? We rub them. And if we do that and the blurriness isn't gotten any better, not good. Patients can also develop what they call double vision, where all of a sudden, instead of seeing one bottle of pop, I'm seeing two, okay? Everything looks double to me. The other thing I want to mention with the eyesight changes is we have had patients that come in and all of a sudden they have a visual field deficit. So all of a sudden, I can't see anything out of my right side. I can only see to the left. This is called a visual field cut, and it happens a lot with our stroke patients, especially the bigger strokes. All of a sudden, they cannot see anything out of one side of their eye. They can see the other side just fine. There's nothing there. It's like black. Okay. Sudden visual changes. E, eyes. This is a big one. F is for face. This is one that you, as a witness to somebody having a stroke, is what you're going to notice. You're looking at someone and all of a sudden you look at them and their face is uneven. Their face is drooping here in the mouth or here up in the eyelid. Okay. Or sometimes their whole face will droop. So if you're looking at someone and all of a sudden their face looks uneven and you notice significant drooping in their mouth, that's not good. The other thing I want to mention with face is people can actually develop almost like a numbness and tingling sensation. Sometimes when you're dehydrated, you kind of get that numbness and tingling sensation. This can actually happen in patients who are having a stroke, where they get that numbness and tingling on the one side of their face. The key to remember, again, if I'm having a stroke on the left side, my right side is going to be affected. So if I have sudden numbness and tingling just on my right side, not my whole face, but just on the one side, and it's happening suddenly, not good. Okay. A stands for arm. So most of us have cell phones, or most of us, we watch TV at night. Okay. So let's say I'm watching TV at night and handling the remote, and all of a sudden I drop the remote and my arm goes limp. Okay. Or I'm talking on the phone and all of a sudden I drop my phone and my arm goes down. Sudden arm weakness. Okay. I can't raise my arm. There's no control against gravity. Okay. It's just hanging there. Sudden weakness, again, it's only going to happen on one side. If you notice weakness on both your arms, it's probably not a stroke. But is it happening on just one side? That's definitely a suspicious thing for a stroke. The other thing I want to mention is, does the arm feel numb and tingling, just like we see with our face? We had a patient probably about 6 months ago, pretty healthy 82-year-old, came in the night before. He was sitting there watching TV, and he noticed he had a little bit of numbness and tingling in his hand. What's our first reaction when we have that? We shake it off, right? Shake out that numbness and tingling. So that worked for a little bit, and then all of a sudden he noticed that numbness and tingling was getting worse, and it was starting to spread up his arm. That is not normal, right? That was a sudden change in that patient's baseline. He then called out to his wife and said, honey, something's wrong with my arm. I don't know, this isn't right. Something's not right. So she brought him in. We kept him overnight, did some imaging, did some blood work. The next morning we did that MRI, and sure enough, he had a very small stroke on the one side of his brain, which is why he had that sudden numbness and tingling. Those were his only deficits though. Okay. But again, he knew that it was not normal. So arm. Yes.
Can we go back to the vision part just real quick?
Oh, absolutely. Yes.
Somebody had the question, does treatment restore the lost vision?
Excellent question. Again, time is brain. When somebody has sudden visual changes, we raise the question, is this a stroke? So in our brain, we have different lobes. We have our frontal lobe, our temporal lobe, our parietal lobe here. So frontal lobe, parietal lobe, temporal lobe is right here by our ears. You think of your temple. And then in the back of our brain, we have what's called our occipital lobe. Our occipital lobe controls vision. Every single area of our brain controls different things. In the occipital lobe is our vision center. When someone has a stroke in their vision center, so in their occipital lobe, it can cause significant vision deficits. However, the field of neurology and interventional neurology, we actually, when people have had a stroke and it affects their vision, we actually have opticianists who specialize in neurological changes. So can it be permanent? Possibly, but we will most likely, if you have vision changes related to your stroke, you're probably going to get sent to one of these specialists. So there is definitely hope. Does that help? So we talked about arm. Now it's speech. S, so we're into the S of BFAST. S stands for speech. This is another one that you as a witness are going to maybe see in someone. Speech. So all of a sudden you're talking to the patient and what? Say that again. Okay. Slurred, mumbled, garbled speech. Or when they talk, they make no sense at all. Okay. So again, you're asking them a question. Not good. Okay. Sudden change in their speech. Does their speech sound strange? Is it garbled? Is it slurred? And again, is it happening suddenly? S stands for speech. T is time to call 911. So to go back to the beginning on my BFAST, this is not a checklist. Okay, I don't want any of you guys to think, oh, well, I have balance problems, but I don't have any of the rest of these. No, you have only one change in any of these things and it's happening fast or quickly. You need to get into the hospital. You don't wait till you have 3 of the 5 checked. You have one of these that is happening suddenly, you need to get in. Okay. And what I will probably do, I can send you, Amy, we have a lot of magnets that we call them our BFAST magnets, and they're magnets you can stick on your fridge that have this exact picture on those. So Amy, I'll probably get your address and I can send you some of the magnets and then you can get them dispersed to the local community there. So. All right, any questions on BFAST? All right, so we talked about the different types of stroke. We talked about how to recognize a stroke. Now, what can you guys do to help control or prevent having a stroke? Okay. Every single one of us, me, Amy, all of you out there, we all have risk factors. Okay. Every single one of us has risk factors, whether they're for stroke, heart attack, cancer. Every single one of us has risk factors. And there are 2 types of risk factors that people have: uncontrollable and controllable. Uncontrollable means we can't do anything about it. It's just how it is. So what are some uncontrollable risk factors that put somebody at risk for a stroke? Age. Unfortunately, as we get older, so our arteries, when we're nice and young, our arteries are nice and open like this, okay? Unfortunately, over time or as we get older, the diameter of our arteries gets smaller. It's just something that happens with the aging process. As my diameter of my artery gets smaller, oxygen and blood flow can't get through here as well as it used to, okay? Decreased oxygen and blood flow causes a person to be at risk for a stroke. Another uncontrollable risk factor is race. African Americans actually have a genetic factor in their blood or in their genes that put them at a higher risk for stroke. So the 2 people I showed you at the beginning, Kirby Puckett and Michael Johnson, both of them are African American, probably contributed to their risk of having a stroke. Women, all the ladies out there, sorry ladies, we are at a higher risk for having a stroke. 2 reasons why we are at a higher risk. One is hormonal changes. Women go through hormonal changes all of their lives. So maybe if they're on birth control medications, maybe during their pregnancy. And then as we get older after menopause, we have hormonal changes that happen after menopause. Hormonal changes can cause the viscosity or how thin our blood is to change. The other reason why women are at a higher risk for stroke is we live longer than men, okay? Life expectancy for women is about 5 to 6 years longer than men. So yay for living longer, but boo, because it puts us at an increased risk for stroke, okay? Family history, we talked about it with the different types of stroke, and we talked about it at the beginning. Know your family history. Any first degree relative, so mom, dad, grandma, grandpa, brother, sister, any family history of a stroke is now going to put you at a higher risk for having a stroke. Can't change your family, right? Your family history, I should say. And then personal history. Somebody who has had a previous stroke or who has had TIAs are now going to be at a higher risk of having a stroke as well. Okay, so those are uncontrollable risk factors. We can't do anything about them. But look at the risk, look at the amount of controllable risk factors that people have. There is a lot of conditions out there that put a patient at risk for stroke, but guess what? We can do stuff about these. So let's take a quick look at these. Atrial fib, we talked about that earlier. Again, that's when my heart rhythm is irregular. Okay, I have that irregular heart rhythm. My advice for any of you out there who maybe you go out in the garden, or maybe you're doing some woodworking in the shop or whatever it may be, and all of a sudden you feel like your heart just, the rhythm of your heart just feels weird. Maybe you feel like your heart's racing, or maybe you feel like your heart's skipping a beat or two. You need to make sure you're communicating that to your doctor, okay? Especially if you're noticing frequent episodes of this. There's a quick test that we can do. We can hook you up to an EKG and see what the rhythm of your heart is. If your heart rhythm is irregular, you're probably going to be diagnosed with AFib, and you're going to need to be put on a medication to help control that. With that being said, any of you out there maybe who do have AFib, you have been told repeatedly, never ever stop your blood thinner medications, your AFib medications. Okay, when you're put on a medication for your heart, there's a reason for it. So never ever stop your heart medications abruptly, especially your AFib medications, because that's going to put you at a very high risk for having a clot, ultimately having a stroke. Okay, the next one is carotid artery disease. So again, oxygen and blood flow comes from our heart, goes up through our neck, and in our neck we have two big arteries. These are called our carotid arteries, okay? When we're nice and young, our arteries look like this, beautiful. No atherosclerosis, no plaque buildup, okay? So oxygen and blood flow can get through those arteries perfectly, okay? However, over time, especially those who have uncontrolled cholesterol levels, those who are smokers, okay, they can build up a plaque in their arteries like so. Now look at the blood flow, and oxygen is having a hard time getting through these arteries. So this is the part of the presentation I normally have people raise their hands for those who have ever had a carotid ultrasound. If you have not had a carotid ultrasound and you meet some of these risk factors, feel free to ask your doctor at your next appointment, "Doctor, I'm wondering if I can have an ultrasound of my carotid arteries." I've even had a carotid ultrasound. Okay, they had a free vascular screening check here. Okay, and they can check and see what is the blood flow like in your arteries in your neck. So next time you go into the doctor, say, "Hey doc, I've never had an ultrasound of my carotids. I'm wondering if I can do that." Literally, it's a quick 10-minute thing. They take an ultrasound, rub it over the carotid arteries in your neck, and see what your blood flow is like in your arteries. When people get to about 70% blockage, so when about 70% of this artery is blocked, they're probably going to get a referral to a vascular surgeon, because we need to clean out that artery, or what we call roto-rooter it. Okay, we got to get into that artery and clean it out before the blockage becomes too much and puts you at a high risk for a stroke. However, that's kind of the last thing. Sometimes you can just be put on medications to help lower that cholesterol, to help decrease or prevent future plaque from building up on the arteries. Okay. Hypertension. We saw it under every single type of stroke that a person can have. Elevated blood pressure, high blood pressure, uncontrolled blood pressure for years puts somebody at a very high risk for a stroke. So with this, my recommendations to all of you out there, know your levels, keep track of your levels, okay? A lot of people nowadays have those little monitors at home. Those little wrist monitors are the ones that fit on their arm, and they check your blood pressure. It's very important that when you're doing that at home, you consistently check it on the same arm. So if you are right, you want to check it on your right arm, consistently check it on your right arm and make sure you're documenting it, log it, okay? Put it down in a notebook. The best time for people to check blood pressure is at 10 a.m. in the morning and 3 p.m. in the afternoon. You never want to check your blood pressure right away in the morning when you wake up because it's going to be very low. You just woke up, you're in a very relaxed state from sleep, okay? Your blood pressure is not going to be accurately reflected. So after you've been awake for a couple hours, that is going to be a more accurate representation of your blood pressure at 10 a.m. Same thing at 3 p.m. in the afternoon. You've been up for a while. You've maybe had a meal. Maybe you've done some working out or been outside. Again, that's going to give you a more accurate reflection of what your blood pressure is. Again, you never want to take your blood pressure at night because your blood pressure is highest at night before you go to bed because of the busy day you had or whatever you might have done during the day. So again, when you're checking your blood pressure, be consistent with where you're checking it. And again, let's say you're checking it on your right arm, and now it's time for you to go in for your yearly check. Ask them to check it on your right arm, not your left. Your blood pressure actually runs about 20 points lower in your left arm than your right arm because it's closer to the heart, okay? So be consistent in how you're checking your blood pressure. With that being said, when you go into the doctor or maybe when you're checking it at home, key things to remember is when you're checking your blood pressure, you need to have your feet flat on the floor, okay? You need to have your arm either below the level of the heart, so down here, or at the level of the heart. So here or here, okay? When you're getting your blood pressure checked, avoid crossing your legs, crossing your ankles, okay? And then no talking while you're getting your blood pressure checked. So even at home, if you're doing it on your little monitor, don't be talking to your spouse or whoever. You need to stay quiet, okay? One other important thing I want you to know is the different levels. We are now considered normal. Our blood pressure is normal if we're 120 over 80 or lower. We are now considered pre-hypertensive if you're 120 to 140 over 80 to 89. And you are considered hypertensive if you're 140 over 90 or higher. This used to be the pre-hypertensive level. What the American Heart Association is doing is they're tightening up our levels because they are finding that when people have chronically high blood pressure, it wreaks havoc on our arteries and our blood and causes people to have big problems with their hearts and their brains, okay? So know your levels. With hyperlipidemia, same thing, know your levels. So every year when you go into the doctor, maybe you go in every 6 months, or at least for sure once a year, you need to make sure that your doctor is checking your cholesterol level. If you've never had a cholesterol level checked, you need to. Anybody after the age of 30 should be having their cholesterol level checked yearly. Cholesterol, what does that mean? Cholesterol is the amount of fat in our blood. So when people have a high cholesterol level, they're at risk for developing this, atherosclerosis or plaque in the arteries due to high levels of fat. Okay, so good cholesterol should be less than 200. We have two types, excuse me, I said that wrong. Total cholesterol should be below 200. With our cholesterol levels, we have two different types, our HDLs, which is our good cholesterol, and our LDLs, which are our bad cholesterol. All three of these levels should be checked yearly by your doctor. Again, your total cholesterol should be less than 200. Your HDL should be around 50, and your LDL, or your bad cholesterol, should be less than 100. So let's say you go into the doctor and it's your first time ever getting your lipids checked and your numbers are a little off. Does that mean you need to be put on medication right away? No. What you can do is you can say, doctor, I don't want to try medications right now. I want to try and lose some weight, switch my diet, and start working out maybe an extra day a week. Okay. You can actually improve your numbers just by doing that, changing your diet, exercising regularly. But let's say you come back to the hospital 6 months later and your cholesterol levels are still elevated. That's when they're probably going to talk to you about taking some medication. So know your levels. Diabetes. This is pretty straightforward. Follow your doctor's advice. Get your blood sugar levels under control. Make sure you're eating a healthy diet and exercising. Pretty straightforward. Diabetics actually are at a high risk for having stroke as well. When someone has high levels of blood sugar, and sometimes we'll see people whose blood sugars are in the 300s or 400s. When someone has that much sugar in their blood, it turns their blood into almost the consistency of syrup. When someone has so much sugar in their blood, it literally turns their blood into syrup-like consistency. So you can imagine a syrup-like consistency blood trying to get through all of our arteries and veins, okay? I mentioned this earlier, smoking, tobacco use, and alcohol. Smoking, I can't say enough about how bad it is for our bodies, especially our vascular system, our hearts and our brains, okay? Again, secondhand smoke does put a person at a higher risk for a stroke, 2 to 4 times at a higher risk. So if you know someone who's a smoker, try and get them to quit. Heavy drinking also increases a patient's risk for a stroke, especially the people who are chronic alcoholics, puts them at a big risk for having a stroke. Does that mean you can't ever have a drink every once in a while? That's fine, but you need to do it in moderation, okay? And then everybody knows physical exercise and physical activity. Get up and get moving. It's very easy to do that this time of year, but in our 6 months of winter that we seem to have all the time, it's very hard to go outside and walk. It's very hard to get out of the house and go do stuff when it's 20 below. So even just doing something in your house, moving around in your house, doing a workout video, if you have an exercise bike, get yourself moving. What happens when we start to get moving, our heart rates increase. And when our heart rates increase, it helps to keep our blood pressure low. Okay. And then the last thing is diet. Everybody has heard about it all of their lives. Okay. We need to watch what we eat, and we need to eat bad foods in moderation. Okay. My most important thing I will say is look at your food labels. Okay. When you're trying to pick a snack for the afternoon, maybe a trail mix is better than a bag of chips. Okay. But look at your food labels. And when you're looking at your food labels, there are 3 things you want to look at: the amount of cholesterol, the amount of trans fat, and the amount of salt. Sugar is also important, but the 3 ones as far as related to stroke: cholesterol, trans fat, and salt. Okay, so read your labels. I'm not saying you can't ever go to the movie theaters and have some buttered popcorn, or I'm not saying you can't at your granddaughter or grandson's birthday party, you can't have a piece of cake. But maybe the next day you need to maybe be a little more careful. Okay, so watch how much you're eating, eat in moderation. Okay. Any questions?
I don't see any other questions, but there are comments. A few people had to drop off, and they're saying that you're an excellent teacher and have good information.
Thank you. Anybody else have any questions at all? This is the time. And yes, I will get Amy's mailing address and get some of those Be Fast stickers. magnets sent out to her, and she can kind of help get those dispersed. And I'll send you quite a few of them. Amy, we have lots of them. And again, now that all of you have heard this presentation, you now get to be the educators, okay? And that's why these presentations are so important, because now the information that I have given to you, you can now go give it to somebody else. You can talk to your son and daughter or your grandkids, or maybe a friend who couldn't make it today, okay? We want you to get this information out to people, because again, the more people know, the more we know.
One question that was asked is they're wondering if we can get the PowerPoint.
Sure, I can get that sent to you.
Yeah,
Absolutely.
if you send it to me, I can send it out to the ones that registered.
Absolutely. Yep. Good. Well, I hope you all learned something and took something back with you, and hopefully you can share that with the next people. And again, I appreciate your time so much. Thank you again, Amy, for having me. This is what I love to do, and I'm just grateful I got to do this. So thank you.